So the HIT expert probability score, the HEP score, definitely represents a means of reducing healthcare costs, reducing lengths of stay. One of the things that happens when someone's diagnosed with HIT or is suspected of having HIT, while the testing is undergone, when they have their blood sent for serologic analysis, patients are taken off all forms of heparin and they're put on what are called direct thrombin inhibitors. Direct thrombin inhibitors are expensive. They're not reversible like heparin products are. So when it's in the system, and the body just has to metabolize it out. So if a patient's in the hospital and is ill and is going to need potential for more surgery, there's a lot of pros and cons that need to be weighed as a result of this. You can't necessarily take someone who's been on direct thrombin inhibitors for an elective surgery by any manner. So, if someone's there and needs emergent surgery, that's definitely a problem. The HEP score has been able to prove that there's a possibility that transitioning patients to direct thrombin inhibitors in the meantime may not necessarily be needed. They can still continue on their forms of heparin. Heparin-induced thrombocytopenia, anyone that's on any type of heparin, so whether it's unfractionated heparin or low molecular weight heparin, there's always a small chance that someone could develop it. They have a very low incidence. It's anywhere between 1% and 4%, depending on what literature you look at. But the thing is it has a lot of complications that are quite devastating, and the cost of treating those is astronomical. So it's best to, be looking out for the potential signs and symptoms. Currently, there's low positive predictive value, low sensitivity and specificity with the current pretest probability models, the 4Ts in the LELO way. The 4Ts, again, has a low specificity, low sensitivity. It's ranging anywhere between 9 and 17%. And then the other test is used exclusively for patients who develop thrombocytopenia but have had recent coronary or cardiopulmonary bypass surgery. Problem is if it's delayed diagnosis, patients can develop DVTs, they can develop pulmonary emboli, they can develop skin necrosis, all of which are devastating and very expensive to treat. There's increased lengths of stay associated with the recovery as well. The HEP score that was developed was a pretest probability score that was used as an alternative to the other test that we already talked about, but there was 100% sensitivity, 60% specificity, but the problem is it was developed just utilizing patients that had been diagnosed with HIT. So my test, I took that same exact HEP score and applied it to patients who were thought to have had HIT, so it wasn't necessarily known at the outset whether or not they had positive or negative testing for HIT. So the sensitivity and specificity for the testing utilizing that particular patient subset was in the 70s, respectively, for sensitivity and specificity, but the one thing that was very encouraging for this test was the near 92% negative predictive value. I think that there's some places that are already starting to use it in practice. The pharmacists at the hospital where I work have been using it. Definitely, some of the things that need to be done are prospective study, because all of this has been done in a retrospective manner, and prospective studies are the gold standard. Any of the tests right now have been utilized at single centers, so a multi-center trial would definitely suit this well so that you have a heterogeneous population.